Thank you, everyone, to the Transplant Surgery Grand Rounds, Transplant Institute Grand Rounds for today, July 30th, I think. I have the great pleasure today to introduce Roberto Hernandez Alejandro. He is visiting us from the University of Rochester, where he is the chief of the transplant surgery, as well as the director of the Transplant Institute at the University of Rochester in New York. And I think just to kind of give a background about where he is, he did most of his training in Mexico. So he went to medical school in Mexico and did his residency in Mexico as well, too. And then completed 3 fellowships, because one's not enough, sort of like Dr. Nagai here, who did 2. He did his initial kidney pancreas fellowship in Calgary, and then followed that with his liver transplant and surgery, liver transplant and kidney transplant fellowship at Western University. For those who don't know from Canada, that is in London, Ontario. That's the closest transplant program to us outside University of Michigan for the most part. And then he has been, after he finished his fellowships, he went back to Western University in London again and became a chief of liver transplant for a few years, and then moved over to University of Rochester in 2016. And since that time, he's been chief of transplant surgery there, and then recently took over, established a transplant institute format at the University of Rochester as well. His main focus, as you will hear today, has been on hepatobiliary surgery and transplantation, especially the connection between the two via using transplant surgery for metastatic colon cancer. As many of you know, it's a field that we started doing recently, but he's been working on for many years. And one of the nice things about it is that I think Dr. Abuju and I both remember that we did transplants for metastatic colon cancer really early in the 1980s, maybe up to the early 90s, before we found out that, oh, this is not necessarily a very good idea. But I think with the leadership of Dr. Hernandez Alejandro and many others throughout the world, this is becoming a little bit more commonplace. So in addition to that, I learned that his kids play hockey, unfortunately, because he's Canadian/Rochester, when we have some Canadian connections here. And in spite of the fact that he's a Pittsburgh Steelers fan, he got roused about in Johns Hopkins. You know, we pride ourselves in the Detroit Lions, but we have not won nearly as many Super Bowls as the Steelers have. So he has a little bit of a head start on us. So with that, I would like to introduce Dr. Roberto Hernandez Alejandro, and he will give us our talk on metastatic colon cancer.
Hello, everyone. Thank you very much for the nice introduction, Dr. Yoshida, and for this invitation. It's an honor for me to be standing here at Henry Ford for giving this lecture to you. Thank you very much again, Dr. Yoshida, for the invitation, your group. Dr. Abuju, thank you very much for hosting me here today. As Dr. Yoshida mentioned, I did a lot of my training, and I worked many years in Canada, in London, Ontario, which is not that far from here. If you draw a triangle between Detroit, Buffalo, and Toronto, London, Ontario is exactly in the center. It takes 2 hours driving to each one of those places. And when I was younger, and there was less gap between me and the fellows, in Canada, we used to come in Thanksgiving to see the Detroit Lions game against the Packers here. It was a lot of fun. I learned about tailgating. It was a lot of fun. And many times I brought my son to see the Red Wings games in hockey. So I have a little bit of attachment to this place, and it's good to be here. We're going to be talking about a topic on liver transplant for colorectal metastases, a topic that is, I would say, very hot topic in a lot of transplant conferences and in a lot of surgical oncology, especially hepatobiliary meetings where we're talking about this more often. So this is my disclosure slides. I have nothing to disclose related to this presentation. So when we talk about unresectable colorectal liver metastases, we know, first of all, that when we can resect the tumors in the liver, that could be the best option for the patients. You could cure the patients and you can give them the best survival for these patients compared to other modalities. But when we call it unresectable, we normally do this when we see in the cross-sectional imaging that we were not able to remove the entire tumors and leave enough liver functional for that patient to survive. So this is an example of what is happening. And I don't know why, but this is increasing more in the world, and especially in the United States. It is more common to see now unresectable colorectal liver metastasis in this patient. And this is an example. And I asked permission for this patient and their family. This is GS, 42-year-old, athletic, minimal alcohol, never smoked, very athletic, beautiful family. They live in Maine. And then she was diagnosed with a CT scan that you saw before. One day she was having blood per rectum. She went to the doctors. They saw a sigmoid tumor, and then a CT scan showed the metastatic disease. That is devastating and changing the history and then of a family. And as GS, there's a lot of population that I mentioned to you that is increasing the incidence of colorectal cancer. As you can see, in the 40s, 30s, and even in the late 20s, it's going up. Why it's coming down in the 80s, 70s, 60s, and 50s is because here we do a good job in a lot of our preventive medicine, that we're doing colonoscopies in patients 45 and above. But there's something that we're doing that is increasing in younger generation. Not sure if it's what probably environmental eating or something that is happening, but more than 150,000 people are diagnosed in the US every year. Half of them will develop liver metastases, whether it's at the time of diagnosis or later on, and is the third leading cause of cancer-related deaths, 1 million deaths per year. So this is not a small part. It's a huge component of the healthcare system. What do we do for these patients who have advanced disease? We have chemotherapy, which has advanced and make a lot of changes over the last couple of decades. And we have biologics. The biologics are like, for example, panitumumab or bevacizumab, where these are not chemotherapeutic agents, but they potentiate and enhance the chemotherapy effect in these patients. And a majority of the patients who have liver metastases from colon cancer, they will have good response to chemotherapy, between 60 to 80, 85% of response in this amount of patients. We have biomarkers-driven approaches. This is for patients who have a more complex cancer disease, and they have mutations in the tumor, which normally mutations are associated to poor prognosis. And there's some directed biomarkers treatments that we are using now, and there's a lot of trials that many other cancer centers are using. And also we have the local regional approaches that we will be using this when it's only the disease located in the liver or dominant in the liver. Resection, it's a local regional treatment. Ablation, the hepatic artery infusion pump that it has been used. It started in New York City at MSK, and it has spread all over the country in many places. Y90 ablations, and nowadays is Trypsi that I think is going to be taking a growth over the next few years. Of course, there's a lot of things that we have to learn about this technique. For me, this is a very important slide that is showing to you the color means the number of liver metastases. It doesn't matter. The tumor burden is so important. So how much tumor is in the liver, whether it's in volume, because a single lesion very large, or it's in amount of metastases. So the more volume, the worse the outcome. So the number of liver metastases or the volume will predict the outcome of these patients. This is survivals. If you go for resection and you have only 1 to 3, probably you have a probability of surviving 5 years of 76%. But if you have many metastases, such as 7 or more, your chance of surviving at 5 years is 7%, even if you go to resection. So this is associated, the more volume, with the worse outcome. Why? Because there's recurrence. And this is what's happening. In this slide, that this is published in Journal of Gastrointestinal Surgery in 2022, we can clearly see that the patients who have no very early recurrence, in the left side of the screen in the blue line, they have a much better overall survival. And if you see in the bottom part of that, the green and the red, the red is the unresectable patients who only stay on chemotherapy. And the green is those ones who have resection, but they have very early recurrence. That means within 6 months. The outcome is pretty similar. So if you have high tumor load, even if you go to resection, there's a chance that your outcome is going to be pretty poor, similar to just staying on chemotherapy. And in the right side, we can see the survival depending on the disease-free survival, how much time it takes to the patient to develop recurrence. And of course, those ones who took more than 2 years of recurrence have a much better survival. What do we do with patients who have unresectable disease? We use chemotherapy. What is their outcome? Their survival at 5 years overall is between 5 to 10%. So we need to do something different. So what happened, as Dr. Yoshida was mentioning, in the 80s and early 90s, there were some groups doing liver transplant for colorectal metastases. And this is a series reported in 1991 by a group from Austria and also some French group, where they compare liver transplantation for colorectal metastases with a therapy that I didn't have idea that it existed at that moment, intraarterial chemotherapy. It was very different of what we use nowadays, but they show a little benefit. They published this. However, later on, it was banned and it was considered liver transplantation for colorectal metastases. It should be a contraindication. You shouldn't use any organs for these patients because they have almost universal recurrence, and the outcome at 1, 2, 3 years was very poor. I think it was around 16% of survival at 3 years or 5 years. So it was abandoned. But what happened over the next couple of decades, we have improved in chemotherapy substantially. Immunosuppression, I think we are better in transplant surgery. And we are able now to measure much better the tumor biology. That, I think, it's one of the biggest components why we can go and revisit these. And this slide is just showing you what I believe this is created by my team about the matter about size and volume, the tumor markers, specifically CEA. But nowadays, we are able also to collect circulating tumor DNA. There's 2 companies. I'm not promoting any of these companies, but we can measure the circulating DNA that in the liver, normally the tumors shed this ctDNA and you can measure it. And there's evidence in resection that if you have a 0 circulating DNA, the prognosis of those patients are going to be better. And this is in resection. If a patient is responding to chemotherapy, the outcome will be better if you do resection. If the patient is progressing in chemotherapy and you do resection, the outcome of that patient is going to be poor. The presence or not of extrahepatic disease depends a lot where it's located for the outcome of the patients. And as I mentioned, the tumor genetics. So 2.5 decades ago, we didn't have these type of metrics. So that's why we can nowadays cherry pick. And this is just to show you the importance. For example, I didn't mention this, but this is the lymph node status. So, of course, the majority of the times when there's metastasis in the liver from colon cancer, there's going to be positive lymph nodes around the primary tumor. That is expected. But if there are positive nodes around the liver or in the retroperitoneum, the outcome is not going to be good. So we need to do a very detailed workup on these patients to see if there's evidence of metastatic disease in the lymph nodes around that area. In resection, this is data from resection, patients who have resection after metastasectomy in the liver and have positive nodes, the outcome was way poorer than the patients who didn't have. And the same thing, as I mentioned, on progression of chemotherapy, this paper clearly showed that probably could be a contraindication for surgery. And this is data coming from liver resections, not for transplantation. And a new part where, for example, MD Anderson in Texas, they look a lot and they check a lot of mutations. The more mutations, the worse the outcome, right? The KRAS mutation, the NRAS mutation, the TP53. To my understanding, there is only one mutations, AMP, that is more associated with better prognosis. But I think we have to do more work into that. So not like more than a decade ago, the group from Oslo in Norway, which they started revisiting this process and of liver transplantation for colorectal metastases. And also, interestingly, is that this is a center, the only transplant center in the entire country of Norway is a center in Oslo. So there's no fights between transplant centers like what happened in this country. And also, it's easy to place policy. They have the waiting time for getting a transplant over there is between 30 to 45 days if you're in the waiting list for any disease like cirrhosis, alcohol, HCC. So you get access to transplantation pretty quick. They don't share with other countries like Denmark or Sweden. So they said, let's start with a trial, and they start doing liver transplant for colorectal metastases. Their first criteria was very broad. So they use only patients who have responded to chemotherapy for a couple of months. And after that, they start looking at patients who didn't have extrahepatic disease, but they were not looking at genetics of the tumors. It was pretty broad, and they start transplanting these patients. And from 21 patients, they were able to see that the 5-year survival was 60%. Remember, I told you that it was 5 to 10% with under chemotherapy. This is opening the Pandora's box. I remember at that time reviewing this paper. I was still in Canada when I reviewed this paper, and I was pretty impressed to see what it was happening there. However, the recurrence was almost universal. But they were able to do more detailed follow-up on these patients, and they start analyzing, and they were in their SICA2 trial, they were able to learn more about details, how to obtain better prognosis. They came with this clinical score. It's called the Oslo score. The more points, the worse the outcome. The less points, the better the outcome for the patient. The largest metastasis size matters if it's more than 5.5 centimeters in this trial. If the CEA, the tumor marker, if it's below 80, if the patient is progressing or not on chemotherapy, and the time interval from the diagnosis of colorectal metastasis to the moment of transplantation. Each one of these has 1 point. If you have 0 points or 1 point, the survival at 5 years could be as high as 100%. And as you can see, if you have 4 points, the outcome is not going to be very good. However, we need to be cautious here. The N number is just 16. It's not hundreds of patients, but this was very interesting. And this criteria has been really adopted. They came later on with something very interesting on PET scans. They do PET scans in the patients before transplants, and they do also PET scans in the in the middle of the observation period of time. And they were able to create a formula where they measure what they call MTV, metabolic tumor volume. And this is looking at the ability of the tumor, how much is highlighting, and if it's they rule a metric above or below 70 cubic centimeters. And if it's below 70, the outcome of the patient after transplantation is pretty good, as you can see in the blue line, compared to those ones who have more than 70. That was quite impressive. When this paper came, we in my center, we were retrospective and we started reviewing. And the only early recurrence and death that we have was above 70 compared to the patients who were doing better. So we, in Rochester, we have adopted this and we follow the patients unless there's a problem with insurance that is not going to be covering the PET scan. So it's not mandatory, but highly recommended in our patients. Now, we have been talking about Europe. So what's happening in this side of the Atlantic Ocean? So we this is the first I think paper from North America where we collaborate, Cleveland Clinic, Toronto, and Rochester. We put a series of 10 cases, and we started doing this with living donor liver transplantation. We believe that perhaps the access with disease organ is not as much as other countries like Spain or Europe. Now, with the new era of the pumps and everything, I think that's another type of conversation that we can have. But we started doing this with 10 cases, and the overall survival at 3 years was pretty acceptable, as you can see here, around 78%, and the recurrence-free survival was above 60% at 3 years. This was pretty acceptable and similar of what Norway was publishing. Now, we went and dive more and with Kazu Sasaki, which he's in Stanford. I think at that moment he was in Cleveland, and collaborating some of our people in our center. And we analyzed the UNOS database since December 2017, which is in this new era, the first liver transplant that took place in the US for colorectal liver metastases until March 2022. At that moment, there were 46 liver transplant performed until that moment. 15 centers has on at least one case. And when we analyzed the survival, right, it was not as good as what we would be expecting here. As you can see, 720 days is just 60%. And if you look at here, when we compare living donors with diseased organs, there was a big discrepancy. You can see this big drop. Initially, there were 2 intraoperative deaths. I think these are patients who were very sick because too much chemotherapy and other problems in these patients who have liver failure and patients who were pretty sick. But you can probably this is related to recurrence. Difficult to know because the SRTR database is not an oncological database. It's transplant database, so it's difficult to see that. I want to show something that it's not published yet. We're working on this. Hopefully we can publish, and this is until March of this year. So from March, 2 years, this is updated 2 years from the previous slide that I showed you. So you can see here in the United States how quickly it's increasing the number of liver transplants performed in the US. This is around 36 patients in the last year. This is in March, it's going up. There's a little bit more of living donors, but also it has gone up the number of diseased organs using in this activity of liver transplant for colorectal metastases. Let's analyze the 3-year overall survival and the disease-free survival. The 3-year overall survival, 65%. It improved from 60% to 65%, a little bit better. Probably it was a matter of learning curve or following the patients a little bit longer. And the disease-free survival is 50%. That is telling us the recurrence rate at around 3 years. I'm not sure if we can trust completely this data because, as I mentioned, SRTR doesn't have all the details on the cause of death of patients. And also, if the patients have recurrence, you don't have to be reporting if the patient is alive. We did exactly the same, dividing in living donors and deceased donors. I'm happy to show that the overall survival here, as you can see on the living donor, improved to 74%. This is more similar of what the other groups in Europe were showing. The disease organ was 54%. There's a substantial discrepancy here. It was not enough, the power, the N number probably not enough to show a significant difference. But I think we have to dive in and to see what is happening here. This is the selection of the recipients, right? Or is this the quality of the graft? We are doing that analysis. We cannot have all the data completely about the selection of the recipients oncologically, but this is quite interesting. And that is why we need to have a registry to understand, a national registry to understand what is happening. And through the ASTS, we were able to come with this liver oncology task force that I was invited to be part of this with Talia Baker and Liz Pomfret and Will Chapman. And we put this, and we were able to get some funding at my institution at University of Rochester. This is not a private thing that we're doing in University of Rochester. There's clearly policies that this is going to be as a group, as a task force of the ASTS, and we call it the arts of the, and we have a lot of institutions already joining us. This is a little bit, few months old, 38 patients at this moment completed, but we are learning about all the details. This is a very detailed registry, and hopefully we can have better answers when we start analyzing. My goal is to be able to have a paper when we have 1 year after this. Let me show you what we have done in Rochester, our protocol. It has, I was talking with Dr. Yoshida about our protocol. It has evolved, and probably in 2 months we will add or change something or remove something. And the Oslo score, for example, for us, if a patient has more than 80, it's a contraindication. So even if it's a single point, if the patient is progressing on chemotherapy, even that it's a single point and the Oslo score will be only 1, we don't think should be transplanted that patient. And for me, the CEA, more importantly, yes, we want to be below 80, but more importantly is what is the pattern? What is happening? If it's going up or it's going down. If I have a patient who has a CEA of 16, and then in 2 weeks it goes to 24, and then in another 2 weeks goes to 50, that's still below 80. That patient is progressing. I wouldn't do a transplant. I will analyze, I will check everything. I will put it in tumor board, do CT scan from head to toes until I find what is happening. And maybe this patient will have to go back to chemotherapy or do something different, but I wouldn't transplant that patient. So we do colonoscopies of the patient. Even if the primary was removed more than a year ago, we do a colonoscopy at like colorectal surgeons survey 1 year later. We don't do BRAF wild type, especially the V600. And if our patients have mutations like KRAS and TP53, or they are right-sided primary colon, I don't understand why, but right-sided colon tumors in the cecum, in the ascending colon, they have worse prognosis, even if they don't have mutations. Don't know why. So we observe them in our protocol. It's 1.5 years at least. In the protocol for the normal patient, the patients who have left side colon cancer and no big mutations, we go for 1 year from diagnosis for colorectal metastasis to the time of transplant. It could be 13 months or 14 months, but minimal 12 months. But those ones who we say they have a higher risk, like right-sided colon cancer, we observe 18 months. We're more cautious with that. I'm showing here 24 patients. We have done 25. This slide was until May 2024. We have appropriate follow-up of 20, so that's what I'm going to be able to show you here. But importantly, there's a lot of work behind to do this volume. There was, at that moment, 225 patients that we evaluated. These are a lot of patients from different parts of the country. This is where we are located, so not that far. To come here in car, I will have to go through Canada, and it will be faster than going in the bottom part of Erie Lake. And then this is where we have referrals, patients contacting us for liver transplant for colorectal metastasis. These are patients who are desperate, that they want to have an option. And a lot of people are offering them, oh, I'm going to do ablation, I'm going to do a little bit of resection, I'm going to put the pump. They hear about colorectal liver transplant metastasis, so they want to learn about that. So people contact, and you spend a lot of time with these people doing telemedicine into this population. The blue lines are where our donors have come from, that we do this with living donor. The red lines are where our recipients. Very few recipients are from New York, and probably a couple of them from Rochester. If I would have only Rochester patients, I will have done 2 or 3 liver transplant for colorectal metastasis. This is the vast majority of the patients. A 3-year overall survival is 90%, and a 3-year disease-free survival is 39%. So I think this is pretty good. I don't think I could be extremely happy, because I can expect that we're going to start having more recurrence and more mortality, because this is when we're going to start seeing after those 3, 4, 5 years. We started our program almost 5 years ago. I think by November or December will be 5 years. So this is, I would say, pretty good of what we're doing. And this is just recently published two days ago, and this was in JAMA Surgery. And we call it progression-free survival for liver transplantation, because we're always talking about overall survival, which definitely we can see that there's a benefit, but a lot of these patients will have recurrence. But this is what I would say the closest to a randomized control trial, which is not a randomized control trial. But if those we evaluated at that moment 162 patients. And we thought that probably there will be 62 that were eligible. These patients were excluded because they have extrahepatic disease, or they were progressing, or they progressed during the observation period of time. Of these 62 patients, we have 33 patients who if I would have a liver in my hands, I would do the transplant in any of them. But 13 patients decided, I don't want to go with Rochester team for having a liver transplant. I prefer to go to XYZ for resection or for ablation or other alternative therapies. And 20 patients got transplanted. And as you can see here, during the follow-up of the time that the follow-up, 75% no evidence of disease after transplantation. The patients who were eligible for transplant but decided to go to alternative treatments, majority of them with chemotherapy plus something extra, they have progression 70%. So this is clearly showing that the population of patients that have a better prognosis if they go for transplantation. This is just a figure that we published. This was July 24, as you can see here. Liver transplant and alternative therapies. The overall survival, I would expect to have a bigger difference the more follow-up because of recurrence, you know, that is associated with poor outcome. And can you say the progression-free survival, that's significantly different in this population. I started presenting about the patient GS, as I mentioned. So she came to us after looking for different places where what's going to happen to her. And patient received chemotherapy. And we decided, okay, you're doing well, responding very well. And as you can see, remember, she had a lot of metastases. And now you can clearly see some calcifications, not many metastases. Well, so it's the moment to remove the primary tumor. We talked to one of our colorectal surgeons in her own state. They were not comfortable doing that because they said, you're not going to be resectable. We were talking about transplantation. They didn't want to do that. So the patient came, and we have to arrange robotic colorectal surgery in our place. Patient came, did it. We did it, and the patient was restarted chemotherapy. I think the period of time where the patient is off chemotherapy before colon resection and after colon resection is a good test, because if the patient don't progress, I think it's a good way of knowing that probably this patient is going to have a better outcome. After that, when the patient was resected the primary, we restarted chemotherapy, and the patient started for a search of a live donor. And this is the brother, lives in Boston, and is a police officer, and he decided to be a donor for her. We do living donor liver transplant. We use the right side, the vast majority of our cases, not only for colorectal metastasis, for our cirrhotic patients that are in the middle of the list or those ones with HCC, or in the bottom of the list, we do living donor liver transplantation. This is Dr. Tomiyama doing the fantastic reconstructions in the back table, and a very nicely reperfused liver with no congestion. And interestingly, if you remember the CT scan that I showed you, the good response that this patient had, some of my colleagues, which are hepatobiliary surgeons, will say, oh, Roberto, you can resect that. Why you're going to transplant this patient? But look at this. This is something that we couldn't see anymore in the CT scans. More metastases in the explant, and many of them with activity of tumor. So this prompted to do some research, and this is Mariana Chavez, which now she was our research fellow for 2 years. Now she's started her fellowship just 2 days ago in Mayo, Arizona. And Mariana did this very interesting research of 14 explants of patients who went for liver transplantation for colorectal metastasis. The first column of livers are the CT scans or MRIs at the moment when they were diagnosed with liver metastasis. The second column is those ones before going to transplantation, after they have resections or pumps or chemotherapy. And you can see where were tumors, and et cetera, et cetera. And the third one is just going and analyze the explants. And 64% of the time we find undiagnosed metastases in the explant pathology when we compare to at least 1 year of chemotherapy on these patients. So this is quite important. We knew a lot of these disappearing liver metastases through surgical oncology, But this is, I think, the first time that we're really proving, because we have the entire liver showing that majority of the time there's more disease of what we can see. And this is another example to illustrate you. This is a patient from Georgia, multiple metastases in the right side. There metastasis also in the left side. Maybe the segment 4 here doesn't have metastasis. This is questionable. The patient contacted us and for patient wanted to have an ALPS procedure, and they said, let's get chemotherapy and see how it goes. And you can see very minimal metastasis in the CT scan in the left side, and the tumors in the right side, many of them disappear, and there's only this one here calcified. We did transplant, and look at this. This is the explant of that patient. Look at the multiple liver metastases that were not seen in the CT scans anymore, and there were more disease of we can see. Now, I show you data from 5-year survival. I show you data from 3-year survival in the United States, but this is the only evidence that we have long-term outcomes, because Norway started doing follow-up for a longer period of time. And this is fascinating for me to see that the long-term overall survival, and this is from the Zika-1. So these are patients, many of them who were not very well selected. And you can see that here it's close to 40% of survival at 10 years. If you look only in this paper to the patients who have an Oslo score of 1 or 2, the survival is above 50% in that group of that population, which is something that we are trying to do similar. Why is it different than resection, and why these patients survive longer? There's a lot of work that we have to do, but also is the recurrence. We mentioned recurrence is worst outcome. The majority of the patients with colorectal metastases that go for liver transplantation, if they have recurrence, it comes in the lungs, not in the liver, not in the graft. Compared to when we do liver resections, there's a higher chance that they will have metastasis in the liver or in other multiple sites, including the liver. And recurrence in the liver is associated with worst outcome. And I think it's because what I show you, that there might be some micrometastases or some disappearing liver metastasis in the liver in the CT scans, but you can see them in the explant. So probably that is the main reason why we're having less metastatic disease, is the power of the total hepatectomy in these patients. So I was asked to present at International HPV about liver transplantation for colorectal metastases, and I couldn't only show Norway and Rochester data. So I did a survey on places in the entire planet doing what I know liver transplant for colorectal metastases. And interestingly, there were some centers which they replied, 45, 36, I will call it, outside the US, and 31 started a liver transplant for colorectal metastases. And you can see here on the blue is the 3% of the people who reply that have done 5 to 10. The vast majority, there's not too much experience in the world about liver transplant for colorectal metastases. Very few programs in the world have done a substantial. We asked some questions in the survey, like, do you use tumor board? 20% of the centers internationally didn't use a tumor board. 1/3, they don't follow the Oslo criteria. A quarter of them, they didn't use genetic testing. And they don't do a laparotomy or laparoscopy trying to find if there's some metastatic disease in the lymph nodes before the transplant. So it was very interesting to see that also 75%, or we can say 1/4 of them, they were not satisfied with the selection that we're doing. And I think this is what it's going to be a groundbreaking thing, and it was just presented in ASCO. The biggest cancer meeting in the world took place in Chicago. I think it was June, at the same time of our ATC, the American Transplant Conference. And Dr. René Adam from Paul Brousse, France, he presented this randomized control trial. So he has 94 patients enrolled, 47 were for chemotherapy alone, 47 went for chemotherapy plus liver transplantation. And he followed up the patients with intention to get transplantation. The survival at intention to treat, you can see here, this is just presented at ASCO, and I felt comfortable of saying that last night I got an email saying that this paper was accepted in Lancet. So you can see here that the survival was significantly different in the patients who have liver transplantation compared to those ones who have chemotherapy alone. This is not showing us something new of what we knew about what Norway showed or what I was able to show with our data in Rochester, but this is the highest level of evidence. And for me, if it's in ASCO, a lot of medical oncologists, this is like their Bible, right? So they're going to start referring patients to transplant centers. And I think this is going to go up, especially in the United States. These are not intention to treat. This is survival as protocol. So if you reach the moment of going to transplantation, then it's even more significant, the difference between chemotherapy to liver transplantation plus chemotherapy. It was quite impressive to see that. We also have progression-free survival that was significantly different as well in a benefit for patients who have liver transplantation compared to chemotherapy alone. I don't think we can call progression-free survival in it would be recurrence in the liver transplant group compared to progression-free or progression of disease in the chemotherapy group. I think at the end, in this country, what we have to do is we need to define what is the acceptable survivability that we can get, because this is a very different population. These are younger people, a very different scenario. They are desperate. They are trying to find who can do something for them. They have built these patients a lot of bridges because they are in their 40s, in their 50s. They are not like our patients who have HCCs or cirrhosis, where it's more difficult to find for them a living donor. A lot of them, they bring 3, 4, 5 people who are living donors. But we have to define, yes, if we are doing a good selection of the criteria of the recipients, we know that we can have a good outcome, right? But what do we target? Do we target 80% survival at 5 years, like what we normally have nowadays in SRTR, which is what is expected? Or do we go for what 10 years ago, Dr. Clavier in the HCC meeting that he has in Zurich that said that it has 60% survival at 5 years for HCC liver transplant? I think there's a lot of questions that we have to define, and also if the community is comfortable with these patients having recurrence, because majority of them, at least 70% of them will have recurrence, many of them in the lungs, but they can go for resection and no chemotherapy, and they can be no evidence of disease, or they can go with some chemotherapy, but these patients live longer. So I think there's a lot of questions that we have. I put the example here in the bottom part about retransplantation. We do retransplantation, and we are not criticized for doing that. And we know that 5-year survival in this population of patients could be between 39 to 68% of survival, and nobody's criticized, but the amount of retransplant that we're doing nowadays is getting smaller and smaller. The problem of this is that now that ASCO presented this paper is coming in Lancet, and the US doing this, as you can see, this is going to go up. So we need to really define what should we target and what is the balance, and find new, better metrics for this. So again, it's been a pleasure to be here. I would like to conclude mentioning that liver transplantation can provide a substantial survival benefit in selected patients with colorectal liver metastases. Parameters reflecting tumor biology are crucial to optimize patient selection. I think it's very important to be strict in our criteria, bring our medical oncology team, our radiologists as well. The early referral to transplantation, I didn't show that data, but there was a paper from my group showing that those patients who get early referral, they get more chances to get into transplant than those ones who got a late referral. And I think it's because the transplanters, we get in communication with the oncologist and saying, continue the chemo, you have a more close follow-up. If the patients stay just with medical oncology, many times they will be treated only like palliative chemotherapy. The multidisciplinary management, including transplant oncology, might improve outcome in selected patients with technically resectable disease. Early access to liver transplantation is crucial. And I just want to define very clear here is we consider unresectable at the moment of diagnosis, and we call it that unresectable disease. If the patient is responding to chemotherapy and turns to be technically resectable in CT scans, we still consider that patient unresectable for colorectal liver metastasis liver transplantation. Thank you very much.
Well, thank you, Roberto, for that talk. I want to let some people want to ask some few questions. I think Dr. Munga here wants to ask a question or two. Go ahead.
Absolutely spectacular talk. We've done one patient so far with a colorectal mets. We're certainly looking to do more. So I have two questions. I don't want to hog the mic, but I have two questions. One is there a standard exception coming for colorectal mets? And if so, can you talk about that?
Thank you. And thank you for making pause between question one and question two, because sometimes I cannot answer the question two, or I ask the second one and not the first one. So, yes, the committee from Liver and Intestine Committee in UNOS, they came with they pushed hard for having exemption points for these patients. And it was approved just a few weeks ago. The initiation of this, we don't have a date. Just digging in and trying to find out, I think it's going to be probably early next year. That's my feeling. Is that going to help patients to getting transplanted? I believe probably, depending where they live. Depending where they listed because of access to transplantation. For example, in my place in Rochester, I don't think they're going to have a benefit of having a deceased organ. It's going to be very difficult. Or I might be able to transplant them with a very bad quality organ, which I personally wouldn't feel comfortable of doing that. Maybe other centers will do it. I wouldn't do it. So I think it will depend where you are. I think one of the biggest advantages of having this approved and moving forward is in this country is the insurance for the patients, because that is sometimes the biggest headache for getting these patients transplanted, because the insurance will say this is experimental, this is not approved. Now that we can show, okay, there's a North American data, there is US data here that we're showing, and then now UNOS approved this to be an indication for transplantation, then insurance, it will be more difficult for them to deny access to transplantation.
So the second question, it's changing gears a little bit, but I'm intrigued that you now are part of this formal transplant oncology group. I'm wondering, one of my pet peeves is, are you all pushing to expand the criteria for HCC? And one example would be patients outside of Milan with well-differentiated cancer. We all know they have really good outcomes. Is that something that will be something your committee looks at?
Well, that's a very good question, because if we look at the outcome of many of those patients, what is reported in the literature, many of them, they're doing pretty well. When I was in Canada, we followed the TTV criteria and total tumor volume criteria. And it would be more or less like close to the UCSF criteria, but we calculated the total tumor volume. And the outcomes were, in the whole country, very similar of what we know about within Milan criteria. I don't know how much we have to do and show to being approved to have exemption points. But there's a good number of patients in this country that get transplanted with outside Milan criteria, but they won't get exemption points, and they will have a extended criteria organ or a live donor, right? But I think I think it should be to have a consensus conference will be pretty helpful to be able to expand and push the envelope a little bit there.
questions. Great talk. Thank you so much. Is there consideration to better standardize the preoperative of these patients? I know you mentioned it. How much transplant have gone for lots of standard post-transplant immunosuppressive regimen that you like?
Great question. Both are great questions. So number one is, I believe like having a champion in each transplant program who say, okay, you're going to be the champion of DCD NRP. You're going to be the champion of transplant oncology. I think for me, in my experience, that helps a lot. So that person or persons should be able to move the needle forward and having that communication with the medical oncology team. We are not medical oncologists. We shouldn't be deciding if the patient receive this type of chemotherapy or other ones. We will learn, and we have learned a lot, and I can talk a lot about chemotherapy nowadays in my experience, but it's just having that communication, having the patient with early referral, understand that the best patient, the selection of patient will be those ones who have good response. I think we have to do more detailed work in those patients who have other local regional therapies. I think that chemotherapy should be the number one treatment that this patient should have. If they add another local regional therapy like Y90 or something like that, could be possible as long as the patient continue responding. Now, where I take the phone and make the and call the medical oncologist is when the patient tell me, when we're following up the patient for that year, they're saying, okay, my oncology will put me on, they call it maintenance chemotherapy. That maintenance chemotherapy for me is like chemotherapy from 1980s. So I call them, and I have to be very cautious how I tell them. I said, well, could you consider going for full chemotherapy? Maybe give a vacation of 3 weeks to the patient, but because if they progress, we have to reset the clock again, and that patient most likely will choose the chances of getting to transplant. I believe there's a window for these patients when we say we can transplant. And the higher the tumor load, I think this window is smaller. We don't know how big is that window for transplanting these patients. So we want them not to progress and have good response. So that would be the combination of communicating with medical oncology for the treatment. And your second question about immunosuppression is, we, of course, were afraid of giving the standard immunosuppression because of early recurrence or something like that. So we came with a cortisone taper very quick. By less than 3 months, they were off steroids. We came down very quick with TAC levels and MMF, and then we went in 500. And the idea was like a 1 year only with monotherapy of TAC. What happened? We saw 4 rejections. Why? These are patients who are 40 years old. They are not cirrhotic, right? They are strong. A lot of them are people who are athletic, and these guys are going to reject. And if you compare our data with Oslo, the vast majority of the patients that they have transplanted are in the 60s or 70 years old. It's a very different disease that we're seeing in age in between America and Europe. That's my, and analyzing the French trial, same, the age is above, here is lower. So I think we have to be cautious. We have changed, we have moved it to trying to change them to an mTOR inhibitor at month 3. The problem is we do living donors, and we have some bileaks. And if you put an mTOR inhibitor when a bileak, there's not going to heal. So sometimes we have to delay. So we haven't been very good at starting at 3 months. We have done it, many of them, when they go very well, 3 months. But if not, we started, 4, 5, 6 months even later. But that's what we have been doing.
Roberto, it's great talk always. And I have a question about logistics, referral or evaluation, and then chemotherapy arrangement. So obviously this is a totally different team, and then the work necessarily compared to like a regular liver cirrhosis patient workup. Can you comment on like how you have built your transplant oncology team, and then what's the role of the colorectal surgeon, the medical oncology, and radiation oncology in this transplant oncology group in your institute?
So it's a very long answer, this one, and it's a lot of logistics, and I'm happy to talk to you about that later on or tonight if I have dinner or something like that. But importantly, this is a very important question, how to build it. The first thing that I did is when I wanted to do this, I wanted to bring someone who knows about this, and the only one who knew was Paul Dag in Norway. So I convinced my chairman and I brought him here into the US, and he gave a talk. And I asked him to meet with the medical oncologist. The medical oncology team was not very, very supportive to be initially. And I started having the first referrals from the community. Yeah, there's an area below Rochester where are the Finger Lakes that we call it the Southern Tier. Beautiful area. There's small pockets of little community hospitals that they are some medical oncology teams. I went there like a drug rep, knock at the door, talk about what we're trying to do, and they start referring some patients until one came. And I know the first one came also from Georgia, trying to get an ALPS procedure or something like that. But this started growing, and then I start showing them some data, and then the referrals start coming out more slowly. But there's a lot of work doing behind. Now, communicating, having a champion is very important. Communicating with the medical oncologist, it's a priority, because that they will like that, and they're more open of what I thought they will be in different places. Because we start having a lot of activity outside the state, we were able to convince. You put some resources for having a navigator. It's not a nurse. It's a very smart secretary that help us communicating with the patients, transferring all the imaging, all the data, put me in contact with the oncologist, and those. That has been a huge help in our side to have kind of a control of all of these. But it takes time and effort, and it works.
So also small steps, and then that's leading to the big team.
Yeah.
Strong team. Yeah. Thank you for your advice.
Any other questions? All right. Well, we'll give you guys extra 2 minutes at the end to enjoy your leftover lunch for the most part. And then thank you very much for all of you attending this grand rounds, and we'll talk to you next month when we have next one.